I'm going to present left atrial appendage occlusion that we did with Dr. Iakovou, Dr. Zarogiannis, Dr. Tzikas. And so it was about a female patient, 80 years old. She suffered recurrent severe gastrointestinal bleedings due to severe, and had also recurrent nose bleedings. She had a paroxysmal atrial fibrillation. She was under Pradaxa, 110 milligram twice per day, and had a very high Chatzitofi score from 6 and a Hasbled score from 3. Of course, she had also her other past medical history was that she had a TAV implantation, a myovalve 24.5 millimeters, diabetes, hypertension, and dyslipidemia. I will skip that because Dr. Tzikas said everything. So I'm going to show you some devices. The most the devices that we implant are the Amphitheatre amulet and the Watchman device. The main difference is that they have both a lobe, but the Amphitheatre has also a disc that closes the left atrial appendage. The amulet is more if I can say, has more bleeding risks because of because of the how it is consisted, but has less leaks and less thrombosis, device related thrombosis. We did a screening for the patient from CT. We measured that the ostium was about 28 millimeters and 40.7 millimeters was the depth. As you can see here in the contrast images and the 3D reconstructions, it was a cauliflower left atrial appendage. So that's why also we did decide that we should do the Amphitheatre amulet so that we can close everything. It was not a really nice circle appendage so that we can use the Watchman. I will go directly to the case. The patient was, of course, intubated. We used the left femoral vein. Okay. So we did the puncture under echo guidance. Parallel, I'm doing also the screening, the 2A screening to be sure that there is no thrombus in the left atrial appendage. Then we start with the transeptal punction. The guide goes up to the superior vena cava, and we slowly come down to the septum, to the fossa ovalis. Once we are in the fossa ovalis, we try to puncture inferior, posterior and inferior. So here we are in, and we place the wire in the left upper pulmonary vein. Here it goes to the left upper, in a minute it goes out. So and then we wanted to place a catheter in order to also measure once again with the contrast. That was a little bit difficult because we had a very prominent ridge, so we couldn't go from the first moment into the left atrial appendage. In the meantime, I measure once again in 0, 45, 90, and 120 degrees. How the left atrial appendage, how long it is. So here we are in, and in the next moment we inflate the contrast agent. Here it comes. We see once again the cauliflower left atrial appendage. So in this time, we measure once again, and we decided that we would place a 25 millimeter amulet. Here Dr. Tzikas is preparing the amulet. So we take the wire, and now we place the amulet. The next moment it comes here. So, and if you see the lobe is opening, and the next moment the disc is coming and closing the left atrial appendage. We are doing here tests to see if it's stable.
This is the disc optimization.
A disc. What did I say?
We optimize the disc.
Yeah. Mm-hmm. Oops. Sorry. Here we optimize the disc, and now here. So I'm checking if you have paravalvular leak.
Show the last angio, the angio. Just.
Yes, I wanted to show the angio. Yeah. It's here. Yes.
Let it play. So it shows that the distal part of the appendix is closed. There is some contrast going through the disc, but this is because the patch that is inside the disc is not thrombosed yet. But this is.
But we see that no contrast is going inside the left atrial appendage. That's what Dr. Tzikas said about the CT. It's okay if the contrast is between the disc and the lobe, but nothing goes in the appendage. And here we released.
Sorry, I will interrupt you.
Yes.
This is not what I said. This is acute closure. The patient is still on heparin, so we don't have thrombosis of the patch that is inside the disc. In a CT in 3 months from now, you might have a contrast going through the disc or even the lobe and go the distal part of the appendage. This is incomplete endothelialization. This is different. The result is the same. That's why it may be confusing. But we expect that this appendage will be closed in a few minutes after we finish. In particular, with the thrombosis of the patch.
So the next speaker is Dr. Vrachliotis, the head of radiology in Onassis Hospital. So what information should we confer to him? So if we do a CT, let's say, in 3 months from now, and what will we expect him to see?
Well, one thing is to see if there is contrast in the distal part. If there is no contrast, it means that it's completely closed, and then you only check for a device-related thrombosis. And you need to understand what is healing and what is thrombosis, because 2 or 3 millimeters of thrombus or black, tissue, if you don't know what it is healing, it's not thrombus. And the other thing is, if you see contrast in the distal part of the appendage, then you need to find a tunnel. Then you need to find the combination of the contrast and a way in and out. And this has to be confirmed with TE.
Yeah, at this time.
And all this will tell you that this is a leak.
You need to have a tandem examination. Good. So, Maria, where are you finished?
Sorry for the
no, it's okay. Actually, that was the case. In the end, I'm seeing only the. I'll show you the conclusion here is the left atrial, the LAAO, the left atrial appendage conclusion. This is shown how it's in the TTE. You see a mass, if I can say, in the left atrium. Patient was fine and was released from the hospital.
So, any questions? Okay.
Simple question. Congrats. I'd like to know your personal workup in the hospital. So the diagnostic workup is by CT always? always. So transesophageal during a procedure, and after there is a program for checking this patient for the leak. I don't know, CT 3 months. That is it? Okay.
Yes. Well, we do a TE when we have contraindications for contrast.
Okay.
When we have renal issues, and then we do TE. But the follow-up for us, it's in 3 months we do a CT or TE, unless, and this is important, unless you don't give anticoagulation to the patient, or you don't really prescribe strong drugs, and you are worried that you might have a DRT, then the follow-up is done at 1 month.
1 month, okay.
Yeah.
And just a brief question. Have you experienced with ice during the procedure and ablation techniques? You close appendage during the procedure or sequential, just this?
Yes, we did the first in Greece, I think it was a year ago, with Professor Vagenakis in Hippocratio, the combination of ablation with PFA and the Watchman implantation.
PFA.
It is really nice procedure. Right now in the United States, 1/5 or 1/4 of the procedures are done like that, of LA closures. It's also reimbursed. In Switzerland and in France, it's also reimbursed to do combined. So this is a trend. The question about ice, ice is good, but ice is very expensive if you don't use it again. And in both the university hospital and the private hospital, at least for me, they don't let me use it again. Although in, I don't know, in Mayo Clinic or in Cleveland Clinic, they are allowed in the US to reuse, but we are not. So I don't know about you, Giannis.
Professor Natale, we have Professor Natale, that the electrophysiologist that perform ablation and always appendage closure by ice at university. But
yes. In Rome or in Austin?
Rome.
In Rome, yes. Andrea, yeah.
So one final question, Apostle. So how would you consider, in the future, for this procedure, LAA closure? Do you think it's going to be valid to have these studies as an alternative to anticoagulants instead of only, like in Greece, we are doing the procedure in patients that they cannot tolerate anticoagulants?
I don't think we are there yet. We will not replace the anticoagulants. No, we will not. But we will treat the patients that cannot take it. And there are many. Or that we treat the patients that take the medication and they have stroke. So if we do this, it's hundreds of thousands of patients. So, but I don't think we are ready to replace anticoagulants to everybody. No. I don't know if it answers your question. Yeah. Okay.
Apostolos, may I ask a question?
Yes.
How are you? Nice.
Your voice is loud and it's strong, yes. And we're very happy to hear you.
Good to see you. And you know that atrial contraction is very, very important when you make ablation. And then we know that when we close left atrial appendage in patients with atrial fibrillation, there's no atrial contraction. And doing ablation, do you think that is it safe? For the device embolization?
No, we don't have issues with device embolizations. But if you want a technical detail, is that when we do these combined procedures, we do the sizing first. Because when we do I don't do one. They do the ablation, you have edema, and the size of the appendix is maybe different. Mm-hmm. So sizing first, ablation, and then implantation of the device. But there is no issue with device embolization related to the heart rhythm. No, we don't.
Do you have any concerns? Do you have any concern about the beginning of atrial contraction can cause some complications?
Are you talking about the left atrial appendage contraction, yes, or the atrial, yes, contraction?
Both of them.
The left atrial appendage contraction, the only worrisome thing is when you have a hypercontractile appendage in combination with an amulet device that might be oversized. I wouldn't do it. I would rather use a Watchman there. But nevertheless, this is not an important problem in our practice. What we care about, we don't worry about that. So
Maybe we have got no information, but I have some concerns because when you restrict the atrial fibrillation to sinus rhythm, left atrial appendage contractions also begins. But we will see the results.
There is no correlation with bleeding. If this is your question, the heart rhythm is not correlated to bleeding, whether the patient is on AF or in sinus rhythm. No correlation.
No, for the device, sizing problems, embolizations, and etc. Because we should talk about this, like you mentioned, first ablation and sizing, then and put the device. This is very important, I think.
I agree, but it has to do with the edema that is created by the ablation. It's not related to the contractility of the left atrium. Do you want to talk about paravalvular leaks now, which is your beloved topic?
I will be very happy.
Or we're not there yet. Wait. First, I think we have. Thank you very much. First, we have, Dr. Vrachliotis, and we'll talk